Okay. First of all, this presentation, most of slide was derived from Medtronic Academy. Our objective in this topic today, first of all, provide a technique for you to complete a successful device follow-up. Okay, company independent, locate threshold sensing and impedance data on a quick look screen, identify diagnostic available to aid in the management of device patient, describe the information available from the arrhythmia episode log that aids in the analysis of patient rhythm and device response. Okay, I will go through this presentation within 30 minutes, and after that, I will show you three cases of live programming from Dr. Mervat Clinic. Okay, this for Medtronic programmer, and I think all features the same. You have here, first of all, to open the programmer or integrator. Then we have paper, and then in every programmer also there is an emergency button. When maximum output are required, press emergency. It will pace alone. Okay, and there is a head and pen. Some programmer have no pen and they have touch screen. Okay, and printer. And what is in it for you? What do you need to feel comfortable with pacemaker follow-up? Actually, we go through every pacemaker or ICD or CRT in a stepwise approach. Using this small thing, PPL stop method, as Medtronic said, P first for presenting rhythm and rate, then P for battery status, lead status, sensing, threshold, observation, okay, event and programming. This is the scheme for every patient had a device, single ICD, single pacemaker, they will ICD or pacemaker or CRTD. We will go through in this thing by systematic approach. Okay, first of all, presenting rhythm. What's meant by present rhythm and rate? First of all, any patient before programming, better to have an ECG, okay, for the patient to see what is the presenting rhythm for him. Atrial pacing, ventricular pacing, atrial sensing, ventricular sensing, or nothing, normal sinus rhythm. Then this first look for ECG give you a lot of information. Evaluating patient presenting rhythm. What is the presenting rhythm? What is the patient indication? Why he put a device? Okay. Does it correlate with the presenting rhythm or no? What is the underlying rhythm? Okay. He had normal sinus rhythm. He had atrial pace. He had AFib. He had pacing, atrial pacing, ventricular pacing. What is the rate? Its intrinsic rate is fast or slow or normal. Is the sensor or lower rate limited control? Are we pacing or sensing? What is the percent of atrial pacing and ventricular pacing? Has any changed since last follow-up session? Here, the pace rhythm recognition. Okay, here we see this single chamber pacemaker. He had ventricular pacing. Okay, then there is sinus rhythm and connected native conduction, then ventricular pacing, then intrinsic beat. In single chamber device as atrial pacing, we have here atrial pacing, okay, ventricular sensing. Rhythm recognition, here we found that there is atrial fibrillation with normal conduction, no pacing, and here atrial flutter also with no pacing. But here he wrote here that VVI at rate 60, so it is expected that there is no pacemaker malfunction. This rate is more than 60. Okay, in the rhythm above screen and the rhythm below. Okay, this rate recognition, atrial pacing, ventricular pacing, and here's this intrinsic rhythm. And this intrinsic rhythm around 75. So DDD pacing, if you know that from a tracking mode DDD, it may give you an idea what's the patient indication and there is underlying rhythms. Patient DDD mode has four different phases of pacing. First, pacing, sensing in atrium and sensing in ventricle, A sense, V sense, or A pace, V sense here, A pace here, the above, A sense, V sense. Here you have a pacing spike here before P wave, this base, atrial pace, and then ventricular sensing. Here, tensing in atrium and pacing in ventricle, like this. Normal P wave, no pacing spike before it, and then ventricular pacing preceded by pacing spike. And atrial pace, ventricular pace, there is pacing spike before P wave and before. Okay. Can we mute the phone? Okay. And what we see this, we are seeing that there is a sense, okay, but there may be VVI pacemaker, there is ventricular pacing, and the spike without ventricular pace, without capture, loss of capture. Why loss of capture? Okay, there is a lot of thing, okay, and here also atrial sensing and then atrial pace after the P wave. Here atrial pace, then followed by P wave, then P wave followed by atrial pace, then P wave followed by atrial pace. So also there is a loss of capture. Okay, loss of atrial sensing and loss of capture, and this loss of atrial sensing because of under sensing, okay, of P wave, and the loss of capture because the atrial pace occurred at absolute refractory period of atrium, and after that, when it become not refractory, it pays, it captured. So it is only loss of atrial sensing. Then we go for battery status, determines the battery voltage, the status calculated as play longevity, measured in volts, battery impedance used to determine replacement time. What mean by RRT, recommended replacement time, ERI, elective replacement indicator. If recommended RRT and ERI is approaching, the battery voltage may help determine when to schedule next patient visit. Okay, here also in Medtronic, here the remaining longevity 7 to 10.5 years. Here we go for data and then battery and delete measurement and press. It gives you a lot of information. The battery voltage here 2.77 volt, the current and impedance, and minimum 7 years and maximum 10.5 years. Also, it gives you data around atrial lead and ventricular lead, amplitude, pulse width, and also impedance.
مسلم
ايوه يا دكتور ميرفت.
انت كلمتني.
ايوه انا كنت منتظر حضرتك بس عشان نبتدي، بس حضرتك اتاخرتي بس. تمام يا فندم.
انا اسفه.
تمام. So this screen will give you a lot of information, mainly the minimum and maximum battery longevity, and also the voltage and impedance of the battery. Okay. Then can we determine the battery status without programmer? Yes, of course, with a magnet. And every company has its magnet rates that give you indication about the pacemaker longevity or life. According to pacing rate when you put a magnet over the device. In Medtronic, give asynchronous pacing, either DOO or VO at rate 85 beats per minute when the battery is normal battery status, and at 65 when the battery is at ARI recommended replacement type. Every company had its own magnet rate. Okay, so if we have Abbott and Pythonic and Surin, every company had its magnet rate related to normal battery life and battery at end of life or battery at sorry recommended replacement time. Then we discussed the presenting risk, battery status, then PPL, for lead impedance. As we know, impedance reflect resistance. Resistance and current flow. Resistance affect current flow. Use the garden here, normal resistance. Okay. Here, low resistance means that resemble to insulation break. And here, fracture, high resistance. Okay, lead insulation break first. Insulation around the lead wire prevent current loss from the lead wire. Electrical current seeks a path of least resistance. Insulation breaks that expose wire to body fluid, which have low resistance. Lead impedance to fall, okay, less than 200 ohms. Current to drain into the body and not reach the myocardium, the endocardium, and battery depletion. Insulation break are often marked by trend of falling of impedance value. We will see now that there is difference between impedance measurement at the time of interrogation, and we should look to the trend of lead impedance through the past time of implantation. An impedance reading that changes suddenly or one that it's more than 30% is considered significant and should be watched closely. And in another side, what mean by lead fracture? Okay, is in lead fracture, it prevent the current to go and impedance will increase. Okay, maybe reached more than 2,000 ohm. Often such increase will be quite gradual, representing a continuing increase in the lead degradation. Current flow may become too low. It is obstructed to reach the endocardium to be effective in generating capture of the heart. If a complete fracture of the wire occur, no current will flow, and impedance number will be indefinite. Okay. Checking the lead impedance, a single lead impedance reading is not enough. Trend should be go over through. Okay, and we during checking lead impedance, we should check both the unipolar configuration and bipolar configuration to determine what is the problem. And this reading will help us to determine the problem and troubleshoot after that. Here, the lead impedance trend in Medtronic. Okay, here impedance Atrium 547 and ventricle 667. How we will go for trend from here. From this battery and lead measurement impedance, also we can go through it, and the trend from here. From this arrow, okay, we click on this arrow, and this will give you the trend. And we see here in the trend that is stable between 600 and 800 ohm. What is the expected range of lead impedance? Anyone can answer? Hello?
Yes, you can answer in the chat box,
Oh,
please.
mm.
They choose B. Okay.
B, yes, it is a correct answer. Between 200 and 2,000 ohm. Okay. Why is knowing the lead impedance important? What is of this answer that applies this question? Okay, it provides detail in longevity, the lead impedance. It may warn you if lead insulation failure or lead conductor fracture at implant. It may indicate a loose set screw. It is not as important as battery status. Actually, it is one of choice already answered. At implant, it may indicate a loose set screw. Okay, and the second answer, it may warn you of a lead insulation failure or lead conductor fracture. So it is also, yeah. If in the case of loose set screw after implantation, within at after implantation immediately, we when measure the battery and lead impedance, we will see that lead impedance give you a high impedance. It directly that there is a loose set screw. And after 1 2 years 3 years lead fracture, it will maybe occur, okay, but it's not in acute setting. And we finish presenting risk, battery status, and lead impedance. We'll go for stop method, the S for sensing. It will be sensed in millivolt, okay, acute phase within 3 months of implant. P wave usually more than 1.5 millivolt, and R wave more than 6 millivolt. It is normal parameters. In chronic phase, after 3 months post implant, P wave mostly more than 1, and R wave more than 5 millivolt. Note that the pathologic risk such as AFib will cause low amplitude P wave, as we know. Okay, sensitivity, as you lower the number here, when you lower the number, okay, it become more sensitive. If we put it here 1.25, I can see this, but if I put sensitivity 5, I will not see this yellow graph, this yellow amplitude. So as you lower the number of sensitivity, you make pacemaker more sensitive. I think it is clear in this diagram. Here, C is too much. He lowered the sensitivity 1.25. So this the pacemaker will see the far field R wave, for example, and it will count it as A wave. Okay, and see the P wave as A wave normally. So I will see so much. Okay, and that is the just right to see the P wave and don't see another far field signal when the sensitivity actually halves the sensing value. Over sensing and under sensing. This also example, there is intrinsic beat, okay, not sensed here. There is V pace, okay, there is under sensing of ventricle, okay, as if the pacemaker saw this beat, it will not label it as V pace. And here the ventricular pacing just at the start of T wave, and this is a dangerous also, can may induce fetal arrhythmia like VF or Torsat, and and that is the problem of undersensing. Okay, here that this is oversensing. We here pacemaker labeled this event, which not appear in ECG, no activity in ventricle, as V-sense. So it inhibit pacing. Okay. So after that also under sensing, V-sense, V-sense, V-sense. And fortunately there is an intrinsic escape rhythm here, but without intrinsic escape rhythm here, this all will be pause. And this also, it is very dangerous to check the sensitivity and to avoid oversensing and undersensing, as undersensing may cause arrhythmia because of spike, ventricular spike will pace on T wave, and it doesn't see that there is intrinsic, and oversensing, it may cause inhibit of pacing. So we just be sure that sensitivity and sensing is appropriate. Okay, you are presented with this ECG strip within the program with the programmed device parameter below. What the area of the strip look abnormal? A, B, C, or D? Okay, actually it is C. Why C? What is this? What causing this? Is this atrial undersensing or atrial oversensing or ventricular undersensing or ventricular oversensing? Anyone can answer this? what you are seeing here. Hello? Okay, ETL under sensing.
Actually,
So it is
understand,
right
sir.
here. Ah, yes. We see the P wave and it is not sensed. Okay. And then after that, spike, atrial pacing occurred. Okay. And not capturing because it paced in the absolute refractive period of the atrium. Okay. What explains that this atrial pace intermittent atrial under sense the P wave was not seen and the lower rate limit timed out resulted atrial pacing. Why this atrial pace not captured? Because it occurred in absolute refractive period of atrial muscle. Okay, what would you do and what would you expect to see? Okay, what will you do? Interrogate and observe the rhythm and check the sensing and adjust the sensitivity. Okay, what you do perform sensing test and check lead impedance if there is anything in lead impedance, and I will revise everything to resolve this under sensing. Suppose the device was programmed with an ETL sensitivity of 4 millivolt and P wave measure 4 to 5 millivolt. Would programming a sensing value of 2 millivolt make it more or less sensitive? It is more sensitive if making sensing value 2. How would you program the sensitivity if you wanted to sense fine AF, for example? Program sensitivity to more sensitive value less than 2 millivolt, maybe 0.5 millivolt to make sure the device sense AF. And the sensitivity and the number will be adjusted according to the sensing value. P wave, how much? P wave 4 or 3. Okay, we will adjust sensing number to 1.51. Okay, but if we found the P wave measure 1.5, we will adjust the sensing number to 0.75 or zero point 0.5. Okay, but if we see the P wave is 5 and we adjust the parameter at sensing value to zero point 0.5, it will make the device make over sensing. Okay, and if we adjust the sensing number at 5 and P wave is 5, okay, so the pacemaker will go under sensing at the same number. Threshold. Okay, so we now in stop method, we S for sensing and T for threshold. Okay, during pacing, the impulse travel via the myocardium, not the native cardiac system. Therefore, the QRS is wide. This is an old version, as now we have a conductive system pacing, so not every paced rhythm is wide. We have a left bundle area pacing and his pacing now. So we, after implantation and after implementation of this device techniques, okay, we show a very narrow and mostly the same axis of normal sinus rhythm. Okay, so this normal QRS and this paced QRS without conductive system pacing. Okay, is there is capture of the heart? I think all of you saw that there is no capture, but here ventricular pacing without capture, then followed by atrial sensing or P wave. Maybe this is VVI, P wave followed by an long PR, then intrinsic conduction. So setting used to ensure capture pulse amplitude and pulse width. Either increase the pulse amplitude or change the pulse width and to adjust the best threshold. And after adjusting the best threshold, we multiply it by 2 for safety margin and adjust the amplitude. There is a big difference between the threshold and amplitude. Threshold is the minimum volt and minimum pulse width to ensure capture of the ventricle, but amplitude should be double the threshold. Okay, here also in Medtronic and in all device, also it give you the threshold here in Ethium 0.625 at 4 millisecond and ventricle 1 volt at 4 millisecond. Okay, and this how we program and how we do threshold test from test. Okay, and we choose threshold, click, it will give us this screen. We choose amplitude, also we can choose pulse width, also can capture management will activate auto capture. Okay, so we choose pulse amplitude and decrement after 5 or 3 or 1 or 2, and we choose the mode which will start the capture threshold, the threshold test. Okay, and also amplitude and pulse width, everything, every parameter we can adjust to make sure that our threshold test will occur normally without anything. Here, keeping pulse width stable, decrement in volts pulse width is zero point 0.5 millisecond and decreasing in the volt, and loss capture here at zero point 0.5 volt. And here the threshold value 1. 1 means that here he go for 1, then 1.5, 1, and zero point 0.5. Lost here, so the threshold here is 1. Okay, and some programmer will decrease by 1.75, zero point 0.5, and in Boston and Pytronic, for example, it will come 1.9, 0.8, 0.7, 0.6, all this. And when loss of capture here, the threshold. We lost capture at 0.5 volt at zero point 0.5 millisecond, so our threshold is 1 at zero point 0.5 millisecond. Okay, and then we can change the pulse width. Okay, here it's changing, the voltage setting is 2 volt, and we are decreasing the pulse width. So we lost here at 2 volt at zero point 0.1 millisecond, and actually the threshold, our threshold is 2 volt at 2.2 millisecond. Okay, here the loss of capture, and here our threshold. Here loss of capture threshold, and here our threshold, and here the amplitude. Final output programming. Final goal, ensure patient safety, appropriate device performance, recommended safety margin, acute. We should give 3 times double threshold, 3 times fold of the threshold, and chronic phase, approximately 3 months post implant. Usually we adjust according double the threshold only, and the auto capture. If we activate the auto capture, it will give automatic capture. It will increase by 0.25 by 0.5 millivolt above the threshold. Okay. Secondary goal, extended the service life of the battery. And this is very important thing, that amplitude value greater than the cell capacity of the pacemaker, usually about 2.8 volt, require a voltage multiplier. So if we found the threshold, for example, our threshold is 3 at 0.4. Okay, this will deplete the battery. Okay, and we should change in the pulse width. So better to make our goal to make the amplitude, okay, adjusted, not the threshold, amplitude below the battery voltage, below 2.8, and the normal value is 2. And if we found that the threshold is 2 or 3, this will cause a battery depletion. Okay. Pacing threshold, what is the pacing output safety margin in a chronic system? Multiply the amplitude by 2. And what is the maximum you would want to program the amplitude, assuming a threshold at less than 1 volt? Normally, try to keep the output amplitude less than 2.5 volt. But take care, the patient safety is paramount. The patient safety is the most thing that we are looking for. If we found this, okay, make the amplitude and then to revise the lead, the position, change the lead, and but keep the safety margin even, but take care that this battery will be depleted and arrange for the cause of this high threshold, maybe medication, maybe lead problem, maybe lead position, and then we correct after that. Then S for sensing, T for threshold, O for observation and data. Okay, what have we checked already? Presenting respiratory status and lead impedance, sensing and threshold testing. Other question to consider is rate response programmed appropriately. Checks the patient achieve rate to support to support the activity of daily living. Is the patient having any arrhythmia? What kind of arrhythmia? Can we program device to extend its longevity? Can we encourage intrinsic event or no? The device diagnostic and observation recording can help answer some of these questions. Here in observations, there is one ventricular high rate episode, 10-day of with 4 hours of atrial tachycardia or AF at times ventricular sense rate more than 100 beat during atrial tachycardia or AF. This means that they had rapid AF conduction and also had AF, so it gives a lot of information. Okay, we should go for every event or every observation and see this true ventricular high rate or AF with fast ventricular response. We should confirm that the patient had AF. In this situation, patient had 10 days with 4 hours. He patient had need an anticoagulation, and at the time also he need a rate control. Okay, so in observation pacemaker it give you a lot of data and a lot of clinical decision. Here also there is a trend, atrial arrhythmia trend and physical rate during an atrial arrhythmia. The patient is static or no, need rate control or no, need anticoagulation or no. تمام. Ventricular rate during AF, details clinical question suggests that medication need to be modified. Okay, if is modification of EV node, if EV node an alternative option like EV node ablation is conducted, AF response is on or no. If not, we would it be useful to try and cardiac pacemaker will go for in details after that. A lot of data you can take from pacemaker and just want to review every data it gives to you carefully and step by step. Here, a lot of things also. Clinical questions, there is increase of stroke during episode. Do daily burden level suggest that patient may be at risk of stroke? Does patient have other contributing risk factors? Should anticoagulation therapy be modified or initiated? And device status, clinical status, and arrhythmia status can all be assessed through not only Medtronic, any pacemaker monitoring and training capability. Comprehensive monitoring and diagnostic information may help to confirm correct operation of the device feature and assess the therapy. And always evaluate pacing percent. Many devices have a pacing percent pacing counter or look at to the histogram. Device longevity is affected by pacing output, and even I informing every fellow that we are putting pacemaker and try our best to prevent it for pacing. We encourage intrinsic risk, and every company had its own algorithm to promote intrinsic conduction. But if we have no intrinsic conduction at all, so we ensure that patient is paced 100%, no problem. But if there is intrinsic conduction, we should encourage, but taking in consideration that this intrinsic risk doesn't affect the patient clinical status. Okay. Here, we should always see the the rate histogram. Rate below the lower rate limit here may because of timing anomaly. It doesn't mean anything, okay? But rate above upper tracking rate or upper sensor rate may indicate an arrhythmia. Okay, here that we see an arrhythmia in pacemaker stored EGM can be useful. Conforming accuracy of other arrhythmia diagnostics is oversensing or triggering arrhythmia collecting arrhythmia trigger. Okay, managing managing AV delay, use auto AV extension algorithm, search AV delay in Medtronic, IVR in St. Jude, and all the thing IR plus. Okay, with auto B verb option to reduce unnecessary right ventricular pacing, allow higher upper tracking rate, guard against retrograde conduction. Here, it is a good example that we see in the surface ECG, atrial pace, ventricular pacing, atrial pacing, ventricular pacing, atrial pacing, ventricular pacing, and then increase the EV delay. Okay, atrial pacing, ventricular sensing, and continue as atrial pacing, ventricular sensing by increasing the EV delay, and this will guard patient regarding that RV induced cardiomyopathy. So we our aim to promote and improve intrinsic conduction and make the pacemaker as a backup for pacing if not if intrinsic conduction is not present. Programming and printing final report. This is the last step in our programming. Okay, prior to printing, have we made all the appropriate change? Are there any feature that could be utilized to promote intrinsic conduction? Do we need to make any change based on testing? What feature is available to clinician to get initial parameter? Here, our parameter mode. Okay, change the mode switch, lower rate, upper tracking rate, rate response, okay, parameters, intrinsic activation, based EV delay, sensitivity delay, BVARP, and the amplitude, sensitivity, all these parameters we can change according what we found during interrogation. And final report, we can print it easily, and that's the revision. B, again, for presenting Risman rate, battery status, lead status, stop sensing, threshold observation, and the program and print. Thank you. And now I will uh, launch another uh, wait, real life case. Okay, here this St. Jude, okay, I put Darrell Shimper pacemaker. This normal, this from Dr. Prof. Mervet outpatient clinic. Okay, this is a real case. Okay, what we are doing here, this is the interface of APOD. See here the capture 1 volt, atrial capture 1 volt at zero point 0.4. Okay, and ventricular 1.25 at zero point 0.4. Last programming 27 of March 2024, sensing 4.4 today, and
Dr.
4.5
Mohammed, sorry to
ventricle.
interrupt you.
Yeah.
The slide share is not open. We cannot see
Ah,
the
ah.
AGMs.
Okay, wait. Stop. Okay, stop
Thank
sharing.
you.
I will share screen. Okay. My screen is now shared or no?
Yes, Mohammed, we can see. Thank
Yes,
you.
Chair
Okay.
Dr. Musallam.
Okay. So here, this is a real life case from Prof. Mervat Clinic. Here, Dell Shimper pacemaker, Apot, this interface, okay, atrium capture threshold capture 1 volt at zero point 0.4 today. Before it was 0.625 at zero point 0.4 at 27 of March. Ventricle threshold 1.25 at zero point 0.4. Before also the same. Sensing atrium P wave was 4.4, ventricle 4.5, impedance 460,340. Okay, and the ventricular pacing was more than 99%. Atrial pacing is 13%. No stored event, and there is only one automatic mode switch episode. Our parameter is the pacing mode DDD 60 over 100 to 130, based and sensed EV delay 225 to 100, AV pulse amplitude 1.5 1.5 at zero point 0.4 pulse. Okay, so we see ventricular sensing test. Okay, we check there is any intrinsic. Yes, there is intrinsic complete heart block. You see, complete heart block. A more than V, and V is regular at rate around 41. Okay, and here 4.5 millivolt ventricle. And sensitivity is 2. So what I did now, I will change the configuration of sensing. See, ventricular sense configuration. I will change it to unipolar tip and we'll repeat the test again. Okay, 6 for 5.5. Okay, and I will also I will check again unipolar ring. Okay, I will give you the unipolar ring. And I already checked the unipolar ring and unipolar tip because the sensitivity is 4. It is a little bit, but it's okay, but it's little bit low. Okay. And you are doing now atrial pacing threshold. Okay. Here I paced in which mode? Which mode I pace? I pace in DDD mode as patient had risk around 40. So I use this pacing threshold at DDD mode and adjust the EV delay, pace and sensitive EV delay, and pace rate around 100. Okay, and started at pulse and in volt 2.4, 2.5 volt. Okay. So here, atrial pace lost here, atrial capture lost at 0.75, and the device wrote capture loss. So our threshold is 1 volt at zero point 0.4 millisecond. Ventricle, I will go for VVI mode and start one with 1.75. Also, we can do it by DDD mode, no problem. Okay, lost here. It lost at 1.25 capture lost, and so our threshold is 1.5. Okay, so our parameters is here DDD, sensitivity is 2, and our sensitivity R wave is 4.5. Okay, so it's accepted here. Sensitivity is 0.5. Okay, and here auto capture already present, and monitor only in atrial lead, and pulse amplitude is 2, and our threshold I think it was 1, and there is a positive margin. Okay, I will show you another uh, device. It is Medtronic. Here also this is the follow-up after implantation, the first of follow-up after implantation of a dual chamber pacemaker with left bundle area pacing. But actually, I didn't have the ECG to show you. Okay. Here, atrial sensing ventricular pacing. It is a young male. Okay, I will. Here I am adjusting this screen by atrial, making atrial EGM here and ventricular EGM here. Okay, and we are doing for sensing now. Okay, here I will go here, sensing now. Test, sensing, P wave, measuring P wave at rate 60, no problem, as our rate is presenting grade is not 79. So we can choose at 60, no problem. P wave is 2.8 up to 4. Okay. And estimated battery longevity here, estimated at 8 years, minimum 6.5 years, maximum 9.5 years, voltage 2.78, and current and impedance is normal. Our impedance 4.7, 458, and volt is okay. Okay. So what I did now, I increased the base AV delay and sensed EV delay. So, and program increased from 140 based EV delay to 240, and sensed EV delay from 120 to 220. Okay, what we saw that atrial pace, atrial sense ventricular pace, it changed it to atrial sense ventricular sense. So I promote the intrinsic conduction as the patient present with 100% pacing. Okay, so I promote the intrinsic conduction. So atrial sense, ventricular sense, atrial sense, ventricular sense. Okay. Here, here. Anyone, can you tell me what I will do now? What is this? Anyone can tell me what I am doing now in this patient? Anyone hear me?
Yes, Dr.
But
Salami,
yes.
I hear
No,
you.
no one have answer. I am doing an EP study by pacemaker. Okay, to check the patient conduction. Okay, so I go here, but you should be an expert to do this, and I know the patient, so I go for EP study from here. Here from this. What? Wait, I will here. Okay, I go for tests now. EP study here and check and choose Paris spacing. Okay. And my Paris mode is OOO, AOO. I want to check the wing path, anti-grade wing path cycle length for this A-sense, V-sense for conduction. Okay. So, and this is cycle length, I will increase. And there is a DVO backup. Here I am increasing the cycle length to 600. Okay. And I will press now. Yeah, minute I see. When back cycle length around 580 here, 11111 conduction. You see? That's it. 1 conduction. ATL pace, ventricular sense. ATL pace, ventricular sense. ATL pace, ventricular sense. ATL pace, ventricular sense. And I continue decrease cycle length until I reach the wing back cycle length. Okay, that is only there is a feature in pacemaker. Every pacemaker you can do an EP study by the device in DDD pacemaker mainly. Okay, and then I adjust my parameters at the finish, keeping the intrinsic risk and battery increase from 9 years to 12.5 years. I increase the EV delay also. I will intrinsic features here. Right. Finish. Okay, I think I am now 1 hour. Thank you so much. If anyone have any question,
Dr. Musallami, I'm Hani Samir. I would like to congratulate you for such a masterpiece presentation. Thank you very much.
thank you, Dr. Head. Thank you so much.
Thank you, Dr. Musallam. I have a question. If you can briefly again explain. I think
Mm.
we do not go for the EP study every pacemaker follow-up patient. Can you guide us which patients are the top priority patients for which EP study should be done through the pacemaker unit?
Actually, we are using EB study. Patient had and we used an EB study for such patient that I want to patient to ensure that patient has intrinsic conduction till which cycle length. Okay, so wing path cycle length when to adjust his upper tracking rate, all of these things I in such patient I explained. Now I want to see the with path cycle length. So not to go for EP study. I can use with path cycle length here. In another patient, some patient presented to you with stored EGM with SVT. Okay, and I can do EP study to prove that this patient had an atrial tachy, there is any jump, there is any echo, beat, okay, to prepare the patient for EVNRT. We used to do it 3 times in last year and diagnosed the patient with SVT with a dual chamber pacemaker. Okay. Also, I want if there is retrograde conduction, patient had recurrent PMT. Okay, he told me I have a palpitation. Okay, every time I have a palpitation and PMT, most of programmer doesn't give you a hint that patient had PMT or no. Okay, and parameters, and there is no atrial tachy, no atrial high rate episode stored in EGM. So I will go for EP study to show the wing pathcyclins for retrograde conduction. There is a lot of things to do by EP study. Okay, in pacemaker, I give you example for a three scenario. You can use an EP study in patient with a pacemaker. Also, I used to do it in very useful situation. When patient come to you with flutter, okay, I can using an EP study, I can stop the flutter, and we did it a lot of time by increasing by atrial pacing, تمام, overdrive atrial pacing uh, to terminate the flutter, provided that patient was anticoagulated, and it's very useful use of the EP study in pacemaker.
Just like we use in ICD patients to overdrive VT, ATP, the
Yes,
concept of
yes.
ATP.
Like VT, but in patient, some patient come present to me at the Prof. Mervat clinic with flutter. Okay, and patient had a 2 to 1 looking atrial flutter. Okay, patient has a very high heart rate. Okay, we stop it by using an EP study by atrial overdrive pacing and stop it flutter within 1 minute. This is a very useful use for EP study in pacemaker actually. But provided
Question is
that
that
patient
there
was
is an
yes,
But Mohammed, this is
another
Dr.
question.
Mervat.
yes, Prof.
Yes, you should be doing it in a hospital
Yeah,
or
yeah.
in the clinic. If you have a DC shock beside you, you never know
Yeah.
what is
Mm,
going to happen. We do
for
it
sure.
because in the clinic we have a DC shock and we have an emergency cart.
For
So
sure.
you cannot do it anywhere without these preparations.
Yes, Prof.
Okay. In
For
case
sure,
it's a
Prof.
risky thing, then we should have to take a high risk consent as well from the patient before doing.
Not high risk consent, but
No, this is a consent only. A consent of the
Only
patient
consent.
and the family. And we tell them we are going to stop this. Sometime, يعني in some occasions when the patient has uh, BT or AF in the clinic, and we have to give him some sedation, and then we deliver shock from the device. This
Yeah.
is done in the clinic, but in presence also of a DC shock and resuscitation.
And in case of emergency also.
Yes,
That
in
is
case
not,
of emergency.
yeah.
Yeah.
Shania, there is an option of exercise testing. I think it is in Medtronic program. When do you use it? Exercise testing, something like that.
Exercise testing. I never use it. When I do exercise, I put the patient. We have also a stress test in the clinic. I put the patient on stress test. Okay, and the programmer header above the pacemaker, and I want to exercise him physical exercise.
Physical.
Okay, to adjust the upper tracking rate according to his physical, not physiological or induction of exercise. I want to see doing exercise, okay, physical exercise, to know actually what he want, what the pacemaker will help him to do his real life exercise. Actually I never use exercise test in program. But
Dr. Hasib, it's a very good question. This is why we have the companies presenting their functions, which we never use. What Mohamed Musallami is saying is also my opinion. We have to. This is why we are asking the companies officially to present the features, or the whole features of their devices, which can help us during our clinical work.
I think this exercise test may be useful in the vitamin stress echo, something like that, to increase the heart rate and see what happened during increasing heart
You
rate.
can prepare these questions, Mohammed, and send it to the
Yes,
Medtronic
yes,
office
yes,
because they
yes,
are offering to give us a high quality specifications
for sure,
of كده. Thank you very much,
for
Mohammed. We
sure.
can shift to the French speaker.
Thank you so much. Thank you, Doctor.
Thank you. Very, very nice presentation, Mohammed Elmosallami.
Thank you.
Last year fellowship program of the Egyptian Board of Electrophysiology, and one of my team leaders and an intelligent electrophysiologist, a booming star, Mohammed Musallami.
Thank you, bro. Thank you so much. Thank you.